Had a really good workout last night, super sore, don't really feel like moving much, might be yawning this video, and that's pretty much all you guys need to know before we can start watching this. So this should be the last video for endocrine pathology. I cut the videos up into smaller sections this time around because I felt like a lot of people prefer watching smaller videos and then they can, space out their gaps or their breaks in between accordingly. Let me see. So last time we left off after finishing up diabetes type 1 and type 2. We came up with a pretty intelligent thing where I told you guys that type 1 and type 2, if you're having any trouble memorizing what type 1 versus type 2, what the differences are, you could just think of type 1 as primary diabetes, where it is primary in the sense that the issue is with the beta cells themselves not being able to work. They're being killed off by glutamate decarboxylase antibodies. And type 2 is secondary because it's secondary to the resistance you have, insulin resistance, right? So you're able to make insulin, but you have insulin resistance. We skipped over all these questions that I'm going to do today. Right? We finished up our dense conversation of DM as well as DI, diabetes insipidus. So that was all done in the last video. Today we're going to continue from diabetic ketoacidosis, HHNS, this thing right here, and then all the men's syndromes, and do a bunch of practice questions in this video, and that's all that's going to be for here. And then I'll come back again after like a 30-minute break to wrap up all of endocrine pharmacology. So what is diabetic ketoacidosis, right? Ketoacidosis is something that a lot of older doctors who possibly came from the East have wrong, right? Because one of the common trends lately in today's time is doing the keto diet, right? Ketogenic diet is not the same thing as being under ketoacidosis, right? One of the most important differences between the two is that ketoacidosis kind of occurs in patients who don't have insulin, right? That's the biggest problem there. If you don't have your insulin, then you end up getting into this hyperglycemic state where you become dehydrated. Alright, so let's take a look at what DKA is. It's one of the most feared complications of diabetes, usually due to insulin noncompliance or increased insulin requirement from high stress, excess fat breakdown, and increased ketogenesis from the free fatty acids, which are then made into ketone bodies. Right, and then you're going to see the question will at some point mention beta-hydroxybutyrate or acetoacetate. So we can stop right here. Let's just go back and check one thing real quick, right? So we saw that when you have insulin deficiency or severe insulin insensitivity, so any type of DM, you're going to have more lipolysis, right, because you don't have insulin. And that gives you more free fatty acids, which allows you to make more ketones, right? And that ketogenesis actually adds to the metabolic acidosis and directly causes vomiting as well. So right now in DKA, that's basically what's happening. It usually occurs in type 1 diabetes where the patient cannot even make insulin, right? As an endogenous insulin, because it occurs in type 1 because endogenous insulin in type 2 usually prevents it. But it can occur in either. It can occur in either diabetes. So one thing that a lot of people don't understand is that even diabetic people can do the keto diet, right? It's actually a great idea for diabetic people to do the keto diet. Anyone who has insulin can do the keto diet. It's when you don't have insulin that you can't do the keto diet because your lack of insulin is actually making you produce ketones already, and you're producing all these ketones while you actually have insulin, not insulin, have glucose in your body, and that really messes everything up. That's when you get this deadly issue of DKA, right? So they have this way of memorizing it. DKA is deadly, so you get delirium and psychosis, cool small respirations, because we just saw there's going to be metabolic acidosis, right? So you get rapid deep breathing to get rid of CO2, abdominal pain, nausea, and vomiting, all because of ketones, and dehydration because you don't have any insulin. So you have hyperglycemia, and that hyperglycemia is causing the dehydration. And so when you look at a disease and you see signs and symptoms for any kind of issue, you should make sure you're able to figure out why those signs and symptoms are occurring. These patients might have a fruity breath odor due to the exhaled acetone, but this doesn't have to be given to you in the question stem. All right. So when you do labs for these patients, what are you going to see? Well, one thing, you're definitely going to see hyperglycemia because they don't have insulin. You're going to see high acid, right, high H plus and low bicarb because they have anion gap metabolic acidosis due to all the ketones they're making. High urine and blood ketone levels. You're going to know leukocytosis, right, something that you can forget, something that you might skip, right? There's an increased white blood cell count, so you definitely want to make sure you remember that. That's something that you can get a specific question on. So you can literally get a question where the whole scenario is about diabetic ketoacidosis, and in the very end, they're like, oh, what would you note in this patient? And one of your answer choices is leukocytosis. You might not associate that with diabetic ketoacidosis at all, so keep that in mind. There is leukocytosis here. Hyperkalemia, but depleted intracellular potassium due to transcellular shift from low insulin and acidosis. Now, this sentence itself is actually very critical, right? The potassium shift is something that we'll talk more about. I think it shows up later on in either hem-onc or respiratory. I can't quite remember. But the potassium shift has a lot to do with insulin. Right? Remember, by the mechanism of insulin release, let's go back and take a look at that real quick. Right, so insulin release actually involved potassium not being able to come out. Right? Remember that the ATP-sensitive potassium channels will close, right? Because what is this? This is your beta cell. You got glucose to come in. You did glycolysis. You made ATP. When you made ATP, the potassium channel closed, so you have a bunch of potassium inside the cell. And then that causes depolarization, and you release insulin. So clearly potassium has a big role to do with insulin. In diabetic ketoacidosis, you note that you have hyperkalemia, right? There's no intracellular potassium due to the transcellular shift from decreased insulin and acidosis, right? Osmotic diuresis, because of course due to the hyperglycemia, leads to more potassium loss in the urine, but your total body potassium, right? You have total body potassium that's depleted. Right, so you gotta make sure you understand that this is, I repeat that here, so DKA, total body potassium is lost, but your extracellular potassium actually remains normal or increased due to the excess KH exchanger activity and lack of insulin, since insulin promotes cellular uptake of potassium. Hence, timely administration of potassium with insulin is key. The serum osmolality is so high, right, the concentration of sugar in your serum is so high that there is a dilutional effect on the serum sodium. So serum sodium is also going to be low, right? And then you can see that right here. I put everything onto this little table. You can easily get a question on diabetic ketoacidosis where you have columns, right? And then they put glucose, pH, bicarb, sodium, NH4, blah, blah, and up and down arrows, right? You got to make sure that you're able to see all the up and down arrows correctly to be able to pick the correct answer choice, because in the end you might be down to two that look the same, and the only way to differentiate would be sodium and ammonium. Ammonium also plays a big deal. Ammonium is the one that has NH4+. So ammonium is actually going to be high in these patients because they have high H+. Right? See, ammonium is high. There's no need for an ammonia buffer anymore, so they have high ammonium. And that's all the stuff that occurs in diabetic ketoacidosis. So glucose is going to be high because there's no insulin. pH is low because they have acidosis. Bicarb is low, again, because of the acidosis. Ketones are high. That's exactly what's happening here. Potassium is within normal limits or high. And this is with reference to your extracellular potassium. But total body potassium is low. And then ammonium is high and sodium is low, right? Because the dilutional effect of high osmolality. So what are complications that can occur here now? Well, for one thing, microbiology gets tied in again. Remember, there's something called mucormycosis we saw from Rhizopus. There's a life-threatening mucormycosis that can occur in diabetic ketoacidosis patients more easily than it can occur in other patients. And of course, they can get cerebral edema, cardiac arrhythmias, and heart failure, all due to the messed up activity of potassium and the acidosis. both combined. All right, so you gotta make sure you keep that in mind. So how do you treat a patient who shows up with diabetic ketoacidosis? Well, first things first, you give them IV fluids, right, because they have very high osmolality, so you have to dilute that. Give them IV insulin, definitely, right, because that's the root cause of why they have this problem. And you have to give them the potassium to replete intracellular stores, right? You only give glucose if it's necessary to prevent hypoglycemia, but it shouldn't really be necessary. So the question will tell you something that'll really point out whether or not you need to give glucose, but usually you don't need to give glucose. They should have some glucose in them. So, make sure you really understand diabetic ketoacidosis. It's not that complicated or hard, but it's definitely very high yield and significant. And keep in mind that anyone can do the keto diet. The keto diet is basically a diet in which you restrict yourself from all carbs and any kind of sugar intake whatsoever. Right? So when you stop eating any kind of sugar whatsoever, your body results to go ahead and break down fat and make ketones, and that leads to weight loss. That's an actual way to lose weight without having to work out too intensely or something. And diabetic patients can do it too. Right? They can do it too, but they have to have their insulin, right? Diabetic ketoacidosis doesn't occur because of any kind of fasting or because of the ketones. It occurs because they don't have insulin. Right? It's two different things right there. This little paragraph here is from a question that tied in biochemistry with the whole aspect of diabetic ketoacidosis. Remember that in biochemistry we learned how you make ketones, right? We saw the whole under metabolism, we saw the whole process of making ketones. So if you've forgotten that, this would be the right time to go back and take a look. Let me just show you what you should be taking a look at. There's this page for sure. You should definitely know this page, right? Understand how many calories you can get from things, and what fasting and starvation does to you. Right? So you see what's happening with fasting and starvation and all of that stuff. Make sure you understand that. And then this page right before that. So these two pages are right next to each other. Ketone bodies and fasting and starvation. You really need to know how you make ketone bodies. And here they tell you HMG-CoA lyase is for ketone production. Right? We all know about HMG-CoA reductase, which we inhibit with statin medications. Though this is the enzyme that makes cholesterol, so you inhibit it to stop making cholesterol. But here you can see all the different enzymes. I've labeled more enzymes into the diagram so you can understand how ketones are made. You see how you have fatty acids that came from fat breakdown, right, because of fatty acyl-CoA synthetase. Then you make acetyl-CoA. That acetyl-CoA gets broken down to HMG-CoA. That HMG-CoA then gets broken down to acetoacetate by HMG-CoA lyase. This acetoacetate then goes into your blood and then gets taken up into muscle. And in muscle, there's an enzyme called thiophorase. Thiophorase is the guy that converts acetoacetate to acetoacetyl-CoA, right? And then that can help you do TCA. So you see how you're able to do this entire thing, and you can do TCA cycle, and you can make energy, you can make ATP without any sugar intake. You're using your own body's fat, breaking it into ketones, and making ATP, thereby losing weight, okay? And this question here was really just teaching you that thiophorase is an enzyme that's not found in red blood cells. So red blood cells can't use ketone bodies, all right? There's other things too. So the liver can convert ketogenic amino acids into ketone bodies. The exclusively ketogenic amino acids are leucine and lysine. The partially ones and partially glucogenic amino acids are isoleucine, phenylalanine, threonine, tryptophan, and tyrosine. If you forgot those guys, you need to go back and take a look. Like red blood cells, the liver is also unable to utilize ketone bodies for energy since it lacks the enzyme succinyl-CoA acetoacetate-CoA transferase. In short, it's also called thiophorase, which is required to convert acetoacetate back to acetoacetyl-CoA so you can then throw it into TCA cycle. Right? So both the liver and red blood cells don't have that ability. So they need to depend on other resources. And up here I wrote that in DKA, the patient will experience increased triglyceride breakdown in adipose tissue if the patient is not on insulin. Triglyceride in adipose tissue are metabolized to free fatty acids and glycerol by hormone-sensitive lipase due to low insulin and high catecholamine levels, like epinephrine and stuff. adipocytes are unable to metabolize glycerol, so it is secreted into circulation and transported to the liver, where it is phosphorylated to glycerol 3-phosphate by glycerol kinase. G3P is one of the parts of fatty acids. The G3P becomes DHAP and G3P dehydrogenase, and DHAP is used for gluconeogenesis. Right, so G3P dehydrogenase is the enzyme that makes DHAP, dihydroxyacetyl something, and that's the thing that you finally go ahead and throw into gluconeogenesis. So you really need to know the biochemistry of the whole aspect of how ketones are made, how you then convert it to throw it into TCA cycle, and then ultimately make ATP. Right? Know the enzymes, they can pop up in a question. No longer are you going to be asked simple questions about diabetic ketoacidosis because everyone knows the simple stuff. Right? So red blood cells cannot use ketones, they strictly depend on glucose, which is why even on the keto diet, you still need tiny intake of glucose no matter what. And no matter how much you try to diet, at some point you will eat something that has some level of glucose in it. And that's pretty much all there is to this page. Yeah, so make sure you come back to this. Make sure you come back to this stuff, understand it today, master it. I remember I told you when we first started, way in the beginning of this playlist, that you always need to go back to different things to study it and master it. Biochemistry is one of those. Right? Biochemistry is something you need to keep going back to. Immunology, you might need to keep going back to. Pathology, you might need to keep going back to as you go through the various system pathologies, and we're in endo right now, so here we are revisiting metabolism. So I put that here, right? The illness or stress leads to excess anti-insulin hormones like cortisol and epinephrine, which can't be met by insulin. So the patient gets anion gap metabolic acidosis and dehydration. This is why increased stress or infection or anything like that can lead to more occurrences of DKA. The glycerol kinase in their liver will convert glycerol from triglyceride breakdown into glycerol 3-phosphate, which then becomes DHAP for gluconeogenesis. Alright, so make sure you understand that entire breakdown, know the whole conversion of things, and then how you reconvert it using thiophorase to something that you can throw into TCA cycle. Right, and that's how the whole thing right here works. The latter half of this page talks about hyperosmolar hyperglycemic state. This is usually going to be an old patient that somehow ended up having dehydration and increased serum osmolality. So we've been talking about osmolality. Remember that every time your serum osmolality is high, that means you don't have water. You don't have water and you have too much of something else in your serum. Right? High osmolality is high concentration. So HHNS, hyperosmolar hypoglycemic non-ketotic syndrome, right? Same name. These are both the same thing. They can be called either one. There's no ketone bodies, which is why it's important to remember the non-ketotic part. This is a state of profound hyperglycemia induced dehydration, which is common in diabetic patients, and increased serum osmolality, classically seen in elderly type 2 diabetics with limited ability to drink. The hyperglycemia leads to excessive osmotic diuresis, so you pee a lot, which is common in diabetics too, leading to dehydration, eventually causing hyperosmolar hyperglycemic state. Symptoms are going to be that of diabetes, so thirst, polyuria, lethargy, focal neurological deficits, seizures because they don't have the ability to utilize the sugar in their brain. And also remember that anytime you have diuresis and increased osmolality and all this dehydration, your sodium levels also get altered. So if left untreated, they can get coma and die. Hyperglycemia will be seen excessively, right? So you can see here sugar is way over 600. This is almost never given to you in any question, right? If you ever get a question in UWorld, Step 1, NBME, anywhere, you're going to get a patient who has a sugar level of somewhere over 200, somewhere between 200 to 300, almost never more than 600. That's crazy, right? That's beyond intense. So if you get a question where they tell you something insane like that, you immediately want to think of this disease. Your serum osmolality will be very high, and there's going to be no acidosis, right? Which is why you have to remember it's a non-ketotic syndrome, right? And pH is normal. Ketone production is actually inhibited in these people because they have insulin. right? So you got to make sure. See, that's the main thing to understand here. If you couldn't figure out why this was not ketotic, then now it should ring a bell that of course these people have insulin. They have diabetes that's being treated, right? These are elderly people that are type 2 diabetics, and of course in type 2 diabetics you can make insulin. You just have insulin resistance. End organ insulin resistance means that you're not going to be able to use the insulin to actually uptake sugar, but the insulin presence still inhibits ketone production. All right, so how do you treat this? You give them the aggressive IV and you give them insulin if necessary, right? You need to give them that rehydration. That's the main issue here. So why does this occur in elderly? Well, this is usually going to be a patient who's hospitalized, he's old, over 60, and is just not really drinking much water. And that's really all there's going to be to it. And because of that, their hyperglycemia, dehydration, and increased osmolality will all lead to HHNS. So I put some information here, and I'm going to show you more information about something earlier too, because NBME is really starting to throw in 0.9% or 3% or etc. percentages with their saline now. They don't just say, oh, you can't just pick the answer choice, give IV fluids. Now you have to know exactly what fluid you're giving IV. So in HHNS, where they have high serum osmolality, they have a lot of solute, you don't need to give them much solute, you need to give them more fluid. So that's why you pick something very low. 0.9% isotonic saline, right, is indicated in every patient with HHNS. Insulin therapy and repletion of electrolytes, especially potassium, are the other cornerstones of management. Right, very important thing right there. Another percentage you need to know is a case scenario where you have to give 3%. And I think that was in DI, right here somewhere. Let me see. What did we talk about? No, not that. Where did I write that? I think it's further up. Hold on. 3%. Oh, right here. Okay. So in people with SIADH, you see this note up here. What happened in SIADH? You had too much antidiuretic hormone, so you have a lot of water in your body, and your osmolality is super low, right? That means you need to give them more solute to make that osmolality normal again. So here you give a higher percent. See, 3% saline. You correct the low sodium in these people because they also have low sodium. Anytime you affect osmolality, you affect sodium. And in these patients with ADH, they have antidiuretic hormone, but also atrial natriuretic peptide active. So at the same time as they're not urinating water, but they are urinating sodium. So they're losing all their sodium, which further worsens the osmolality. So you have to give them 3% saline with the goal of increasing sodium by about 6 to 8 milliequivalents per liter, right? Because you have to correct sodium very slowly, otherwise you can cause osmotic demyelination syndrome. So you really need to know these percentages. Just know it at the back of your head. You don't have to memorize it hardcore, but know it so that when you see it in your answer choices, you can pick it, right? So that's something I definitely wanted to come back to. Now, with this patient, you just give 0.9%, and that's going to take care of their issue. So let's take a look at this question down here now. So this is from Amboss. It says, a previously healthy 15-year-old girl is brought to the physician by her parents for lethargy, increased thirst, and urinary frequency for 10 days. She is 5 feet 8 inches tall and weighs 120 pounds with a BMI of 18. Physical exam shows no abnormalities. Serum glucose is 224, which is pretty diabetic. Urine dipstick is positive for ketone bodies. Which of the following is most likely involved in the pathogenesis of this patient's condition? So given her age, right, and the fact that she has weight loss and she has all the other symptoms of diabetes and she's making ketone bodies, you know that she doesn't have insulin, right? Because if she had insulin, she would not be making ketone bodies. So thereby, we can establish the fact that she has type 1 diabetes, right? Her age further encourages that, and the fact that you can see ketone bodies also encourages that. A type 2 diabetic would have insulin, but they would have insulin resistance, so they would present without ketone bodies. So this patient, the answer was T-cell infiltration of pancreatic islets. This slim adolescent presents with classic features of type 1 DM, polydipsia, polyuria, hyperglycemia, and ketonuria. in patients with type 1 diabetes, infiltration of autoreactive CD4 and CD8 T cells into the pancreatic islets leads to the progressive destruction of insulin-producing beta cells, which ultimately results in insulin deficiency. The immune system is thought to be activated by one or more environmental triggers, viral infection, dietary factors, whatever it might be, in genetically susceptible individuals. The loss of functioning beta cells continues over months to years. Symptoms usually manifest once 80 to 90% of beta cells have been destroyed. And there's really no stopping it. It's just going to happen, and it can happen to anybody. So don't get sick, I guess. But really, it can just happen to anybody, so it kind of sucks. The last thing before we go into all the questions, right, there's a bunch of questions on this page, and then a bunch of questions afterwards as well to really tie in DM and DI, so stick around. The last thing we're going to have to do right now is just MEN syndromes to wrap up endocrine pathology. Very high-yield topic, very tricky topic, and Step 1 loves it, right, because you can throw in so many different pathologies. MEN syndrome, which is multiple endocrine neoplasias, uses multiple endocrine cancers. So it's a great topic to test people on. You can throw in pituitary, pancreas, and parathyroid, thyroid, adrenal, and mucosal neuroma. Any kind of cancer, and then all of a sudden require your students to kind of really catch what's wrong with the patient. So look at MEN1. MEN1 is one thing, and then MEN2 are both sort of related to each other more. So MEN1 has pituitary tumors, pancreatic tumors, which can range from Zollinger-Ellison, insulinoma, VIPoma, or rarely a glucagonoma, and parathyroid adenomas. So they're going to have excess PTH. It's associated with a mutation of MEN1 gene, which is a menin tumor suppressor gene on chromosome 11. So remember, with tumor suppressor genes, they have the 2-hit rule, right? You need both of the tumor suppressors to stop working before you actually end up getting MEN1. And these patients also have some extra things. They'll have angiofibromas, collagenomas, and meningiomas, which you can easily forget or skip over. And you might see it in a question and really think it's not that big of a deal. So, watch out for that. You can get a question where they're going to try to come up with some kind of tricky reassortment of these diseases or these cancers, tumors, whatever you want to call them, and really expect you to know what else you should be expecting in such a patient. So if I give you a patient who has a history of parathyroid adenomas, so they got their parathyroid and thyroid removed, and I tell you that today he's presenting with angiofibromas on physical exam, and maybe he has, and the reason he really came in was because of a pituitary tumor, you should immediately think this guy has MEN1 and really start giving him a full evaluation to check for any other MEN1 associated tumors he might have. Right? That's really what they try to do with MEN disorders. They try to give you a history of multiple different cancers or the presentation of different cancers, and then they'll expect you to know what other cancers this patient might have. So MEN1 has the most things to it, actually. Right? There's so much variability in how a MEN1 patient can present. MEN2A and 2B are both associated with the RET gene, a mutation in the RET gene, which codes for the receptor tyrosine kinase. Right, so RET gene here too. So what's up with that? Well, MEN2A has parathyroid hyperplasia, medullary thyroid carcinoma, which is pretty much the defining factor here, and pheochromocytoma. But you see how you see medullary thyroid carcinoma in both? So at least, if anything, right, the medullary thyroid carcinoma is what's supposed to really help you figure out that it's MEN2 and not MEN1. You don't see that in MEN1. MEN1 does not have any thyroid carcinoma. All right. So as soon as you see a thyroid carcinoma, you can forget MEN1 and then really start thinking of MEN2. And for MEN2, the difference between A and B really comes between whether or not there are parathyroid issues or mucosal neuromas. Right. So let's take a look at each one by one. So MEN2A, parathyroid, medullary thyroid, and pheo. Right. So you're going to get a patient who might have both parathyroid and thyroid carcinoma. So they get their thyroid removed. Now, think of this, though. There's this little tricky thing here, right? So maybe the patient actually had a parathyroid hyperplasia a long time ago. They might have started getting symptoms of hypercalcemia, so they got their thyroid and parathyroid removed a long time ago. So this patient is presenting with a weird history where their thyroid and parathyroids have already been removed, right? And then today they're presenting with hypertension. Immediately, you need to start thinking of things that can cause hypertension, and because they have a history of thyroid removal, you will never find out if that patient actually ended up getting medullary thyroid carcinoma or not. But if you ask them why they had their thyroid and parathyroid removed, they might tell you, oh yeah, I had excess calcium in my body for some reason. Then as a doctor, you understand that they have a history of parathyroid hyperplasia. They might have had a risk of getting medullary thyroid carcinoma, but they didn't because the thyroid was removed. And now they probably have a pheochromocytoma, which is why they're presenting to your clinic with hypertension, right? Especially treatment-resistant hypertension. Like no matter what you give them, ACE inhibitors, ARBs, whatever, their blood pressure is not going down because of the excess catecholamines that they're making from their pheochromocytoma. That's a very interesting, tricky way to test you on this topic. Men2B is the easiest to identify because they only have the thyroid and pheochromocytoma, realistically. And then if they really feel like helping you, they'll tell you about the ganglioneuromatosis they can have. Mucosal neuromas, very rarely they'll give it to you, but really they should be throwing intestinal ganglioneuromas at you, right? And if they throw an intestinal ganglioneuroma at you, you need to know what that looks like. Right? But basically, it's just going to be a neuroma in their intestines, and they'll tell you about that. It might be impeding the flow of food in their intestines and stuff. And you should associate that with Men2B. You can see that Men2B has nothing to do with the parathyroid, nothing to do with the pituitary, nothing to do with the pancreas. Right? 2B is super easy. It's just the thyroid and pheo. That's it. Whereas 2A is the one that has your parathyroid, thyroid, and pheo. And since the parathyroid and thyroid kind of go together, these patients present weirdly because if they already got their thyroid removed, they won't ever get thyroid carcinoma. So you're not going to see that in the question. You have to evaluate that from your own thinking. And we're going to see a couple questions that do that. So let's take a look at this question right here. This one says, a 34-year-old man comes to the clinic due to frequent clumsiness. For the last 6 months, he has had recurring minor injuries from walking into doors and stationary objects. So that kind of tells you like he's kind of going blind in a sense, right? Or not exactly going blind, but he can't see correctly. He has some kind of visual irregularity. Past medical history has recurrent renal stones, for which he underwent neck surgery 3 years ago. So that's a huge deal right there. Physical exam shows bitemporal visual field defects. In addition to brain imaging, what else should be screened for tumors? So you know immediately that because of his pituitary involvement, the pituitary is only part of MEN1, that this patient might have MEN1. Right? Pituitary involvement was MEN1 related because this question is not going towards the direction of like a prolactinoma or acromegaly, none of that, right? So that's already out of the question. And then past history of recurrent renal stones really makes you think he might have excess calcium, which is causing calcium phosphate stones, right? And they tell you that he underwent neck surgery 3 years ago. Neck surgery for someone with renal stones usually means you remove their parathyroid gland because they were making too much PTH, which caused them to have hypercalcemia. Right now, you know that because pituitary and parathyroid are involved, you should really check their pancreatic function as well. Right? MEN1 has hyperparathyroidism, for which he had neck surgery, and pituitary adenoma and pancreatic tumors. So that's the only other thing he has not yet shown. All right? Keep in mind that all three of these guys are autosomal dominant, so these patients might also come with history where they tell you that someone else in their family has also gone through something similar. And let me see. And then there's this question right here. This is also from Europe. This one says a 22-year-old man comes to the office with a thyroid nodule. So now you're thinking there's a thyroid cancer involved, and if a thyroid cancer is involved, that's got to be MEN2, right? Medullary thyroid carcinoma. It doesn't have to be MEN2, but if the question goes towards men, then you have to think of MEN2. He first noticed a small nodule on his lower neck 6 months earlier, and it has since enlarged. The patient has had no change in weight and otherwise feels well. Okay. Past medical history is notable for seasonal allergies. He takes no medications. Physical exam reveals a 2-centimeter thyroid nodule and mucosal neuromas of the lips and tongue, which then should immediately ring a bell for MEN2B. On further investigation, the patient's arm span is noted to exceed his height, and he has long fingers, which is because men 2B has a morphinoid habitus. Right, morphinoid habitus. Serum calcitonin levels are elevated because um, the medullary carcinoma it's got the C cells in there. And which of the following is most likely to develop in this patient? And the answer was episodic headaches. Right? It's not going to be hypercalcemia because he doesn't have a parathyroid adenoma. It's not going to be hyperglycemic episodes. That's more diabetes related. Peripheral vision loss, no. And recurrent peptic ulcers, that would be men 1. Right? If they have a gastrinoma or something. So episodic headaches, because this patient with men 2B is going to have a pheochromocytoma possibly, and that's going to cause the headaches, right? The migraines and everything, hypertension. So that's it for that stuff. This is an image from something older that a lot of people preferred over what First Aid has now. So if this helps you more, that's perfectly fine, right? Men 1 has 1 M and 3 P's for the menin gene, and these 3 P's are the 3 different organs that are involved: so pituitary, parathyroid, and pancreas. And then men 2A has 2 M's and 2 P's, whereas men 2B has 3 M's and 1 P. So you see how the number of M's and P's is kind of switching up. And this diagram really does help a lot of people kind of master it a little better than the way First Aid shows it. So if you like this diagram more, go ahead and use that. The last thing on this page is another AMBOSS question. So this one says, a 31-year-old man comes to the physician because of worsening abdominal pain and inability to concentrate at work and a general lack of motivation over the past several months. This air conditioner makes so much noise, it's so annoying. He has a history of spontaneous passage of 2 kidney stones. His father and uncle underwent thyroidectomy before the age of 35 for thyroid cancer. Physical exam shows diffuse tenderness over the abdomen. Serum studies showed elevated PTH. Okay. Further evaluation would most likely show elevated levels of what else? So you can already see in this patient all the things that are occurring and paint a little picture of what Men's syndrome it must be. So you would note elevated urine metanephrines, a young patient with primary hyperparathyroidism, right? The elevated PTH is leading to hypercalcemia, and you're seeing symptoms of stones, bones, groans, all of that stuff. And the family history of thyroid cancer should really raise suspicion for multiple endocrine neoplasia 2A. Or either one. It doesn't have to be just, well, since the parathyroid is involved, it is exactly 2A. But if they don't tell you all that, it's just, you know it's meant to because there's an involvement of the thyroid. Increased levels of catecholamine metabolites, such as metanephrines in the urine or serum, are diagnostic of pheochromocytoma, a catecholamine-secreting neuroendocrine tumor typically located in the adrenal medulla. Right, and pheochromocytoma can be seen in 2A or 2B, but you know this guy has 2A because he has parathyroid issues, right? Men 2A has parathyroid issues, whereas men 2B does not have the parathyroid, right? Instead, it has mucosal neuromas at the top. So very important to remember that. So now that we're done with all of that, we can actually start diving into questions. So I'll scroll back up and start from the questions up here, right? So we have a bunch of UWorld and AMBOSS questions mixed in related to the pathologies that we've been studying in the past few videos. And then we'll call quits for the endocrine pathology, and I can finally get started on endocrine farm video. So first question here, 21-year-old college athlete comes to the office due to recent weight loss and fatigue. The patient states, my coach wants me to put on more weight, but I cannot seem to do it. It doesn't matter how much I eat, I keep losing weight. I've been really thirsty and drinking lots of water lately too, and it's causing me to use the bathroom frequently. I'm afraid I will be dropped from the team. He is sexually active, and his father had colon cancer at age 64, which is literally just bullshit information to throw you off. Which of these studies would be the next best step to establish diagnosis? You can get a patient like this in step 2 CS as well. Right? You know from everything he said, and you don't even need the sexually active and colon cancer part, you already know he's got diabetes, right? And since he has diabetes, that's it. You just got to check for his fasting blood glucose levels, right? This same question had other answer choices too. It also had the do a 2-hour oral glucose tolerance test. You don't do that. Right? The 2-hour oral glucose tolerance test is something you really only do for pregnant patients because they might have that diabetes, the gestational diabetes, and that's it. But realistically, just fasting blood glucose is perfect. The patient's symptoms are suggestive of type 1 diabetes, where because of lack of insulin, he's losing weight. Remember that it's not diabetes that makes you fat, it's insulin that makes you fat. And a diabetic patient will actually be skinny if they're not treating their diabetes. Specifically, type 1 diabetic patients are going to be skinny because they can't make any insulin. Right? Type 1 diabetes is very different from type 2. In type 2 diabetes, there's high amounts of insulin, and it can cause the patient to become fatter, but not necessarily either. The real issue is obesity, right? It's the other way around. Obesity is the thing that leads to diabetes, but diabetes does not make you obese. So that's it for that first question. The next one, 34-year-old woman comes to the clinic due to dizziness and mild confusion over the last week. The patient has a history of seizures beginning in childhood and was recently started on carbamazepine by her neurologist. Her temperature is 98, blood pressure is fine, and respirations are 13 per minute. Physical exam is within normal limits. Lab studies show a low serum sodium. What does this patient have? And the answer was SIADH. Causes can include a multitude of drugs, including carbamazepine, cyclophosphamide, and SSRIs. SIADH is a very interesting disorder, and you won't really exactly catch it from the description of the question either, but because they told you she was started on a new medication, you could go ahead and pick SIADH, right? She has inappropriate ADH, high amounts of water retention. The low serum sodium is not due to the ADH, but rather due to the ANP that people with SIADH release. Remember that in SIADH you have volume expansion, you have too much water in your body, so your body tries to make you euvolemic, right? Euvolemic hyponatremia occurs because you're going to start releasing ANP to pee out more sodium, right? So that's why they have low sodium, but their body volume is going to be just normal, right? Otherwise, I would state that this question is relatively difficult because not much is given for you to really identify SIADH, right? But it's a good enough amount of information to pick SIADH if SIADH is one of your answer choices. Next question here is 60-year-old man is brought to the emergency department due to altered mental status. His wife says that he had a nagging cough that worsened over the past several months, and he began experiencing occasional dizziness earlier this week. Over the last couple of days, the patient became increasingly confused, and today he does not make any sense at all. He has no significant past medical history, but has smoked a pack of cigarettes daily for the past 40 years. On physical exam, the patient is incoherent but has an otherwise normal neurologic exam. Chest x-ray reveals a mass in the right lung. Lab results show sodium of 120, potassium of 4, BUN of 12, creatinine is 0.8, and calcium 9, with a plasma osmolality of 250. Urine drug is negative. What else might you find? So now, this question does a better job of telling you that this patient has SIADH, right? Their sodium is low. Remember, sodium is supposed to be from 135 to 145. You have to memorize these numbers, and the best way of memorizing these numbers is by actually doing questions and looking at the numbers over and over, because you really don't want to be using that reference table. Like, yeah, it's going to be there, but you save so much time by not wasting your eye power and brain power trying to find that number. So this patient has low sodium, right? But their osmolality looks okay. Remember that the plasma osmolality was supposed to be about 300. Urine osmolality is supposed to be about like 600 to 800, something like that. So what would you find? You would find apparent euvolemia, right? Because in SIADH you have euvolemic hyponatremia. The volume normalizes because of ANP. So the combination of hyponatremia and the lung mass are suggestive of SIADH. Small cell lung carcinoma are neuroendocrine tumors that can release ADH, leading to hyponatremia, low plasma osmolality, and high urine osmolality, peeing out all the sodium, which leads to seizures, altered mentation, and weakness, as you can see in this patient. ADH causes water absorption at the kidneys, and the volume suppresses the renin-angiotensin syndrome system, leading to sodium excretion. As a result, patients have euvolemic hyponatremia. No features of volume overload will be seen because of the ANP, atrial natriuretic peptide, which kind of helps you with the edema, but also makes you lose more sodium. All right. Next question, 46-year-old woman comes to the office due to a painful rash involving her groin and legs that has been worsening in the last 2 weeks. And this is how they always love starting this question. She was diagnosed with DM 6 months ago, but has no other problems besides occasional loose stools. Physical exam shows coalescing erythematous plaques with crusting borders and a brownish induration. What does she have? She has a glucogonoma. Remember, glucogonoma kind of presents in a very weird manner with this rash that they get. Let's kind of go back and take a look at that in case some of you forgot. So I think it was right in the beginning. Yeah, right here. Right, so remember in glucogonoma you get the 5 Ds, dermatitis, which is a necrolytic migratory erythema. It's actually painful. It'll be in the face, groin, and extremities, right? Painful erythematous lesions. They have diabetes, which we already saw. They can get a DVT, weight loss, and depression, right? So really important to watch out for such a question where the question starts with this weird painful rash and the question doesn't give you anything about infection. The question might actually throw in zinc deficiency because in metabolism, in biochemistry, you see that zinc deficiency also causes a weird kind of rash in the groin area, but it's not the same thing. It has nothing to do with diabetes, nor does it have erythematous crusting plaques and stuff, alright? So glucogonoma was the answer for this question. Next one, 28-year-old woman comes to the clinic due to generalized fatigue and frequent urination. She cannot recall when her symptoms began. She has no significant medical or surgical history. She's having difficulty being a single working mother with little social support and occasionally uses alcohol and marijuana to help calm down. Physical exam, including vital signs, are normal, or is normal. Blood glucose is 95 and plasma sodium is 132. Alright? Urine osmolality during a standard water deprivation test shows that the urine osmolality increased from 130 to 520 during water deprivation, with no further changes when vasopressin is administered after reaching the 520. Okay, what is the most appropriate treatment for her? Literally, all you have to do is do a water restriction. She has hyponatremia with a low initial urine osmolality of 130, making psychogenic polydipsia most likely. Water deprivation helps differentiate between psychogenic polydipsia and diabetes insipidus. The patient is deprived of water until urine osmolality reaches a steady state maximum of about 520. 600 is normal, is the number we're working with, right? Then vasopressin is administered to see if there is any additional increase. But in psychogenic polydipsia patients, urine osmolality increases rapidly when water is withheld, and giving ADH will have no effect. They already have ADH. They're able to make ADH. This patient does not have diabetes insipidus. So it's really important to be able to differentiate between PP and DI. And if you're having trouble with that, you really need to look at more questions and maybe watch that video one more time about DI. Because if this was a patient with diabetes insipidus, giving ADH, right? Giving ADH was supposed to be the thing that actually caused something to occur. But in this patient, water deprivation alone caused her urine osmolality to increase, right? What does that mean? So this patient had a urine osmolality that was 130. 130, right? Because she was peeing a lot of water. 130 is low. Low osmolality means that there was low concentration in the urine and there was a lot of water in the urine. When she stopped drinking water, right? If she had DI, if she had diabetes insipidus, then that means that she doesn't have ADH function. So when she stopped drinking water, her urine osmolality still should have stayed 130. Why would it get better? Right? There's no way it can get better. She's still going to dehydrate and she's going to pee out all of her water. But that's not what happened here. As soon as she stopped drinking water, things got better. Her urine became more concentrated and ADH is working. Right? And now if I give her more ADH, I'm not going to see a symptom. I'm not going to see any kind of change. A lot of people, for this kind of question though, will fall for picking nephrogenic DI because they're like, oh, giving it ADH didn't do anything. It must be nephrogenic DI. But that's not the issue here. Water restriction alone made things normal, right? When she stopped drinking water, her urine osmolality became 520, and urine osmolality normally ranges from 500 to 800. We're working with the number 600, so it's easier to memorize. Serum osmolality is supposed to be more than 295 or something. We're working with the number 300 to keep that easy. Right, so that's what you really want to grab in this patient. And they gave you a lot of reasons she could have psychogenic polydipsia because she is very stressed out. She doesn't have social support, stuff like that. But NBME isn't that nice, and step 1 doesn't have to be that nice either. They'll literally just tell you a patient came in with frequent urination, you do the water deprivation test, water restriction test, and their urine osmolality increases. As soon as you take away water, if their urine osmolality increased, that means things got normal again, and she just has PP, not DI. Now take a look at this next question. 58-year-old man comes to the physician because of 1 month history of increased thirst and nocturia. So same kind of thing again. He's drinking a lot of water to compensate for any dehydration. His brother has type 2 diabetes mellitus. Physical exam shows dry mucous membranes. Lab studies show a serum sodium of 151 and glucose of 121. A water deprivation test shows the table below. What is the best diagnosis? So you look at the table, and this is the table right here. So you can see serum osmolality, initial presentation is 295, right? After 3 hours without fluids, it goes up to 305, and then they gave ADH and it went back down to 280. Urine osmolality, right? Urine osmolality initially was 285, which is very low, right? It's supposed to be about 600. You stop giving them water, and it doesn't really get that much normalized. You see, it only slightly went up. Just because there's no water intake now. That's it. But it didn't normalize. It didn't normalize like the other patient here in this question up here, where when you stopped giving them water, it went all the way up to 520 again. Right? So water deprivation did, after 3 hours without any fluid, any water, it didn't really fix the urine osmolality. And then when they gave ADH, there is actually a change, right? There's a change. You can see it got even better, right? It's going towards a better direction, 355. And eventually it should get better. That means that if giving ADH helped and taking away water did not help, then this person has DI. And the fact that giving ADH was able to help things, that means that they're not making ADH, so they have central diabetes insipidus. But this question got a little funky. They chose an answer choice called partial central DI. This patient's polydipsia, polyuria, and inability to concentrate urine after a water deprivation test are diagnostic of diabetes insipidus. His responsiveness to an ADH analog, which is indicated by the increased urine osmolality, rules out nephrogenic DI. The degree of responsiveness to desmopressin allows partial DI to be differentiated from complete central DI. In partial central DI, urine osmolality increases by approximately 10%, while in complete central DI, urine osmolality increases by 50% and becomes much more normal than just, 355. It would have became like 520 like the previous patient. So that's the little difference between partial and complete DI, something that UWorld teaches. So you can go ahead and try to, keep that in mind too. Complete central DI is defined as an increase in urine osmolality of over 50% when you give desmopressin. All right? But forget the complete and partial stuff, like that's not so bad. Generally, really understand the difference between PP, which is this first patient up here, and DI, which is the second patient here, right? Major difference that really helps you grasp the diagnosis of the two diseases, right? In psychogenic polydipsia, when you stop drinking water, things normalize immediately, and your urine osmolality increases. Your urine becomes more concentrated, and there's less water in your urine now because you stop drinking it. But in DI, there's always going to be water in your urine, and no matter what, because you don't have anti-diuretic hormone, right? So you can't stop putting water in your urine. So just because you stop drinking water doesn't mean your urine osmolality will increase much. It just increases a tiny, tiny bit because you stop drinking water. So there's really not much water to pee out anymore. And then you give an ADH analog to differentiate between central and nephrogenic. If it's nephrogenic, even giving an ADH analog won't help because the kidney can't work with it. All right. So that's really all there is to that. This is some more information on diabetes that we've already talked about. And then down here is another question. So let's take a look at this one. AMBOS. 55-year-old woman with type 2 diabetes comes to the physician for evaluation of worsening tingling of her feet at night for the last 6 months. 2 years ago, she underwent retinal laser photocoagulation in both eyes. She admits to not adhering to her insulin regimen. Her blood pressure is 130/85 while sitting and 118/70 while standing. Examination shows decreased sense of vibration and proprioception in her toes and ankles bilaterally. Her A1C is 11%. Urine dipstick shows 2+ protein. Which of the following additional findings is most likely in this patient? And the answer that you might not even think of was incomplete bladder emptying. They had a bunch of answer choices, but the rest didn't really make sense for someone diabetic. This patient has clinical and lab evidence of poorly controlled diabetes, including an A1C that's really, really high. It's almost double. Peripheral neuropathy, nephropathy, and retinopathy. The presence of postural hypotension in this patient suggests diabetic autonomic neuropathy, which is a subtype of diabetic neuropathy that results from poorly controlled diabetes and is characterized by damage to small fiber autonomic nerves. Genitourinary manifestations of diabetic autonomic neuropathy include incomplete bladder emptying, urinary retention, erectile dysfunction, retrograde ejaculation, and dyspareunia, pain during sex. So this is a really cool question. I love this question. I put it here because incomplete bladder emptying or incontinence, urinary incontinence, is a very high yield topic for step 1, and obviously diabetes is a very high yield topic for step 1. So this question combines the two things, and you really need to make sure that you know the two things are related to each other. All right. Cardiovascular autonomic neuropathy, which often affects patients with long-standing diabetes, would present with resting tachycardia, orthostatic hypertension, syncope, arrhythmias, or sudden death. And gastrointestinal manifestations of diabetic autonomic neuropathy have esophageal dysmotility, gastroparesis, which leads to chronic diarrhea or constipation, depending on what's the patient's diet. And the gastroparesis presents with nausea, vomiting, bloating, and early satiety, abdominal pain, and weight loss. So these are other things that you can see in diabetic patients whose diabetes is really poorly managed, right? And it's a very common thing. A lot of diabetic patients will keep coming back to your clinic every 3 months with an A1C that doesn't seem to go down below 10%. Why? It's not just because they're not taking their medications. They might be taking their medications just fine. It's really because of their lifestyle and diet, right? They can't stop eating rice. They can't stop eating their sweets, their juices, and whatever else they enjoy. So no matter what, everyone's body is different. The medications don't necessarily have to help everyone the same amount. That's a very common thing to occur. So you really want to make sure you know all the things that can occur to a diabetic patient. Then we have the last few questions on this page right here from Amboss. So first one, 24-year-old woman comes to the physician because of a 2-month history of increased urination. She also has dry mouth and excessive thirst despite drinking several gallons of water daily. She has a history of OCD treated with citalopram. She drinks 1 to 2 cans of beer daily. Physical exam shows no abnormalities. Serum studies show a sodium concentration of 130, which is low, a glucose of 185, and an osmolality of 265. Urine osmolality is very low, 230. The patient is asked to stop drinking water for 3 hours. Following water restriction, repeated lab studies show a serum osmolality of 280 and a urine osmolality of 650. So you can already tell by this point that this patient has PP, right? Because as soon as she stopped drinking water, her urine became more concentrated, all by itself. She has ADH activity, and she was able to stop urinating water simply because she stopped drinking water, all right? Which of the following is the most likely diagnosis? Primary polydipsia, and that's it. This patient has polyuria, polydipsia, and both low serum and urine osmolality because she has too much water, and it all corrects. Everything becomes normal as soon as she does water deprivation. Note also that this patient has another psychiatric illness of OCD, which helps you kind of think of, psychiatric polydipsia, because that's kind of psychogenic polydipsia, because that's also sort of a psychiatric thing. And that's really all, right? That's it. So this question, the other questions that we just did about DI and PP should really help you identify the difference between the two. This one, 46-year-old man comes to the physician for a follow-up exam. He has type 2 diabetes and hypertension. Current medications include metformin and lisinopril. He reports that he has adhered to his diet and medication regimen. His A1C is 8.6. Insulin glargine is added to his medication regimen. Which of the following sets of changes is most likely to occur in response to this new medication? So glargine is a long-lasting, you have the word large in glargine, it's a long-lasting insulin. Right, so if you look at your answer choices, they're about glycolysis, glycogenesis, lipolysis, and gluconeogenesis. Okay, so first things first, you don't want to mess up what you're reading, like I was about to, because I almost said glycogenolysis or whatever. make sure you know what's happening. So glycolysis, glycogenesis, lipolysis, and gluconeogenesis. So all you need to figure out is giving insulin is going to cause what to occur with these guys. And clearly the answer must be B. If you give insulin, you should have more glycolysis. You should have more glycogenesis, which means you're making more glycogen because you're actually taking the sugar and putting it away, right? You're going to have low lipolysis, which is the main reason why insulin presence kind of stops you from making ketone bodies. You can't make ketone bodies if you're not doing lipolysis. And there should be low gluconeogenesis. Why would you be making more sugar if you have insulin and you're able to take up sugar already from your diet, right? So that's it. It was a really straightforward question, very easy answer choices, but a lot of people actually did get this question wrong too, just because of all the answer choices here. And then spend some time really grasping the biochemistry, right? Because I put the biochemical explanation here as well with GLUT4, the F26BP, right? Make sure you go back to biochemistry, metabolism, and really know how F26BP helps you with glycolysis versus gluconeogenesis, right? F26BP with 2 phosphates increases the activity of glycolytic enzymes, breaking down sugar, right? Because if you have all this phosphate activity already, that means you must be eating, right? It's the fed state. Without any phosphates, that means you're having free sugar, and you're making free sugar because you're fasting, right? PFK is also the other guy that you really need to know well, as opposed to F16BPAs, bisphosphatase. So make sure you understand that. I talk about this very well and very clearly in my metabolism videos as well. So if you need to go back to that, check that out. Whatever it is, make sure you're able to talk about all of this very accurately without messing up. The next question is 78-year-old man. So 78-year-old man is brought to the emergency department by his wife because of a 3-day history of worsening lethargy and confusion. His wife reports that last week he was diagnosed with a urinary tract infection and was prescribed antibiotics. He has type 2 diabetes for which he takes insulin, but he frequently misses doses. Examination shows dry mucous membranes. Serum beta-hydroxybutyrate is undetectable, so there's no ketones. Urine studies show high glucose and no ketones. Which of the following sets of serum findings would most likely be found in this patient? So, what's wrong with this patient? So, first things first, I've always told you guys, if you read a question and the age is either really, really high or really, really low, think of something that's unique to that subset. This is a 78-year-old man, and the only 78-year-old man stuff we know from our endocrine thing was the HHNS thing, right? The hyperosmolar, hyperglycemic, non-ketotic syndrome, right? HHNS, yeah. So that's why this patient has no ketones, right? No beta-hydroxybutyrate, because they have insulin. This patient has insulin. It's a diabetic patient that has insulin. It's type 2 diabetes. They're able to make insulin. But the real issue here is that this person was not drinking enough water, right? That's why they have mucous membrane drying up. They have dehydration. You look at all your answer choices and you remember that this was a case scenario where we were supposed to see crazy high amounts of glucose. So we can cancel out choice B, right? Choice C and D are both 450. C and E are both 450 glucose, and A and D are extremely high. So I'm leaning towards A and D because those are like super, super high glucose levels, but 450 is also very high. Now, in such a patient where they're not drinking enough water, right, osmolality should not be low, right? It can't be low. Why would it be low? Osmolality should be high because they have a high concentration of solutes and not enough water. So when I look at my answer choices now, for osmolality, I can cancel out B, I can cancel out E, because those two guys are low, right? A and D have a high osmolality, C is relatively high as well. Now we look at sodium. What happens to sodium? Well, normal sodium is between 135 to 145. In this case scenario, with this kind of patient with having diabetic ketoacidosis, we talked about, not diabetic ketoacidosis, with HHKS or HHNS, this patient should be kind of losing a little bit of sodium, but it shouldn't be high. Sodium should not be high. There's no reason for it to be high. They already have high amounts of solute in their serum as it is, that solute being glucose, so they're not going to have high amounts of sodium too, right? Not going to make sense to have both of them to be in there. So now I'm down to just the 3 answer choices where the 132 is there, right? And I already knocked out Answer choice E, so we're really between C and D now, right? 132, 132. Now you look at bicarbonate. And in HHNS, there really isn't an issue with bicarbonate, so you should be able to pick D. Right? D is the answer choice. And if you couldn't do the bicarbonate part, you would really be confused between the other answer choices. In fact, if you really started with the bicarbonate part first, you would still be, at a good spot, and you'd be able to cancel out answer choices. So let's take a look at the explanation. This patient has glucoseuria without evidence of ketone formation, negative urine ketone and serum beta-hydroxybutyrate, as well as signs of dehydration. In the setting of a recent stressor, like the UTI this guy had, probably because of his bad insulin adherence, these findings suggest a diagnosis of hyperosmolar hyperglycemic state. Patients with hyperosmolar hyperglycemic state typically present with marked hyperglycemia, so glucose is over 600, which in turn causes increased serum osmolality. So now they have high concentration of stuff in their serum, so over 320. There is typically negligible ketone formation due to the presence of endogenous insulin. Sodium concentrations are usually decreased due to extracellular water shift from the hyperosmolarity. So bicarbonate is going to be consumed rapidly only in DKA, but individuals with HHS often present with normal or only mildly decreased serum bicarbonate concentration. Right? And that was it. That was the only way to knock it out. Choice C is consistent with diabetic ketoacidosis, which was another answer choice many people picked, but there was no reason to pick it because there was no ketone production. Alright, he has type 2 diabetes. There was no ketone production. The patient has insulin. Insulin is not going to let you make ketones. It's not going to let you do lipolysis, and that's really all there was to it, right? So although what looks like a hard question, it's really easy once you learn how to, finally get to the answer choice. 32-year-old. So 32-year-old woman comes to the physician because of a 6-month history of a recurrent rash, okay? She describes the rash as reddish spots that gradually increase in size and form painful and itchy blisters that ulcerate before resolving spontaneously and reappearing in another location a few days later. So now you should kind of know what's happening to her. The patient reports frequent episodes of watery stool over the past 6 months. During this period, she's also had a 17-pound weight loss. 1 year ago, she was diagnosed with diabetes and was started on metformin. Physical exam shows multiple crusty patches with central areas of bronze-colored induration and tender eruptive lesions with irregular borders on the legs, buttocks, and around the lips. The Nikolsky sign is negative, which means it doesn't just scratch off. A skin biopsy of a lesion shows epidermal necrosis. What additional finding is most likely in this patient? So she clearly has glucagonoma. You're seeing the 5 Ds again, the dermatitis, the declining weight, right? She has diabetes. We don't see about a DVT here, but she's not doing too well, right? So you're going to know increased fasting serum glucagon concentration. This patient's rash is consistent with necrolytic migratory erythema. Migratory, right? There aren't that many kinds of rashes that occur in one place, then disappear, and now occur in a different place and disappear. That doesn't really occur, right? It's not a very common thing. Glucagonoma is the first thing you should think of when something like that pops up on your step 1. And the rest of it just falls into place. So pretty easy, right? Necrolytic migratory erythema is a paraneoplastic cutaneous reaction associated with glucagonoma. All right, mechanism isn't understood, so thank God for that. Previously healthy 14-year-old girl is brought to the emergency department by her mother because of abdominal pain, nausea, and vomiting for 6 hours. Over the past 6 weeks, she has also had increased frequency of urination, and she has been drinking more water than usual. She has lost 6 kilograms over the same time period despite having a good appetite. Her temperature is 98.8 Fahrenheit. Pulse is 125, respiration is at 32 per minute, and blood pressure is pretty low. So pulse is very high too, right? 125 is high. She appears lethargic. Physical exam shows deep and labored breathing and dry mucous membranes. The abdomen is soft, and there is diffuse tenderness to palpation with no guarding or rebound, okay? Urine dipstick is positive for ketones and glucose. Further evaluation is most likely to show which of the following. So the answer here was decreased total body potassium. Her deep breathing, right, deep and labored breathing, her age, 14-year-old, and the fact that you see ketones are all a sign of a patient with type 1 diabetes because of her age and the fact that she's making ketones because there's no insulin around. Type 1 diabetes, and now she has diabetic ketoacidosis, right? In diabetic ketoacidosis, total body potassium is low. All right, and that's what we're going to explain here now. So this patient presents with acute abdominal pain, nausea, vomiting, lethargy, and a 6-week history of polydipsia and weight loss, together with small breathing, deep and labored breathing, dehydration, glucoseuria, and ketonuria. These symptoms indicate DKA, which causes an anion gap metabolic acidosis. DKA typically occurs in individuals with undiagnosed, untreated type 1 diabetes. Untreated because once you start treating with insulin, they're not going to get the ketoacidosis. Failure in known diabetics. Absolute insulin deficiency results in hyperglycemia and hyperosmolality. Right, the concentration of sugar in your serum increases, so low water. As a result, potassium shifts along with the water from inside cells to the extracellular space and is lost in the urine. Moreover, the insulin that normally promotes cellular potassium uptake is absent, compounding the problem. A total body potassium deficit therefore develops in the body, although serum potassium may be normal or even paradoxically elevated. So it's a very strange thing, but you really need to know it. It's a very key thing that's pretty unique to DKA. So total potassium is lost, but your serum potassium is pretty normal. Last question here is a MEN syndrome. So a 40-year-old man comes to the physician because of a 1-month history of a painless lump on his neck. 2 years ago, he underwent surgery for treatment-resistant hypertension, episodic headaches, and palpitations. Physical exam shows a firm, irregular swelling on the right side of the neck. Ultrasonography of the thyroid gland shows a 2-centimeter nodule with irregular margins and microcalcifications in the right thyroid lobe. So the thyroid is involved, which means it's not MEN1. Treatment-resistant hypertension, so that's a pheochromocytoma. And further evaluation is most likely to show increased serum concentration of what substance? Well, if the patient has MEN2A, then calcitonin. Well, calcitonin is related to MEN2 in general because it comes from the medullary thyroid carcinoma. So it was a pretty easy thing, but we can't really tell from this question if it's MEN2A or 2B, right? But calcitonin is a sure shot answer to pick because he has the thyroid cancer, and medullary thyroid carcinoma releases calcitonin. So that's all it was to it. Right? We don't know though if he has 2A or 2B. So that's the only thing. To figure out if it's 2A or 2B, you could do a physical exam, see if there are any mucosal neuromas. Otherwise, for 2A, you could see if the parathyroid is involved. Right? If the parathyroid hormone is elevated, or you're seeing any history of hypercalcemia in any way whatsoever, that would give away 2A. Okay, so that's it for that. We're done with all of endocrine path, and in the next video session, I'll try to go into endocrine pharmacology and really wrap that up in one video because it's very short. It's very short. You really need to spend a lot of time right now going back to biochemistry, going back to SI-ADH, making sure you understand how ADH works, making sure you know all the complications of diabetes, and really being able to identify the correct answer when you get a question about psychogenic polydipsia versus SI-ADH versus diabetes insipidus, right? Step 1 loves it. Step 1 loves that stuff, all right? So thanks a lot for joining. I really hope that all that stuff made things clear, and the practice questions really help solidify stuff, and then I'll be back in a little bit to finish up endocrine pharmacology.